Okay, everyone, so let's get started on drug-drug interactions. If you have any questions or if you skipped a video and need some more clarification on what I'm talking about when I'm thinking about SIPs and mentioning enzymes and all that stuff, make sure to watch the Pharmacokinetics 101 video or just to read the beginning pharmacokinetics PK part of this same presentation. But without further ado, let's get started with our drug-drug interactions. So first we begin with our concomitant use of blood thinning drugs. So concomitant use is something that I'm going to be talking about quite a bit over the course of this lecture. And concomitant use, all that means is the use of multiple drugs together at the same time. If you're using multiple drugs at the same time, you are using them concomitantly. So if you're using drugs together, it's concomitant. Now, concomitant use of medications that have the same side effects or that are harsh on the same parts of the body can lead to issues, hence problems with bleeding and blood thinning medications. So blood thinning and antiplatelet medications used individually might not cause these issues. They might have a risk of these issues, but when you use them together, that risk is magnified because if they all have a risk of bleeding and ulcers, and you're using 3 drugs that also have a risk of bleeding and ulcers, you have a much higher risk, 3 times the risk, or something along those lines, of having a bleeding problem. So we want to look out for drugs on a medication list that show up where these people are using them concomitantly. So antiplatelet drugs, such as clopidogrel or Plavix, NSAIDs, which can be always very harsh on the gastrointestinal tract. They can cause peptic ulcers like the ulcers in the stomach that you can see right there, or another bleeding risk, so like bruising, bleeding, and clotting. They might also be quite commonly appear. These side effects like bruising, bleeding, and clotting might quite commonly appear in patients who are taking these drugs that might all produce some sort of bleeding risk. They might be bruising easier, they might have nosebleeds more often. But anyway, antiplatelet drugs, NSAIDs, and anticoagulant drugs, anything that thins the blood thinners, all used together. So our NSAIDs are our aspirin, ibuprofen or Advil, naproxen, otherwise known as Aleve or naproxen, and celecoxib or Celebrex. Although we should note with Celebrex that because Celebrex is a bit more selective in how it treats that inflammation as a non-steroidal anti-inflammatory drug, there is a lower bleeding risk with Celebrex as there is with other NSAIDs. However, Celebrex is certainly not the most used NSAID because, of course, naproxen, aspirin, and ibuprofen are all over the counter, while Celebrex, celecoxib requires a prescription. Next, we also have our anticoagulant drugs, which can also cause issues with bleeding when used with antiplatelets or NSAIDs. This is probably what you see the most often, especially people who might have a headache or something, so they take ibuprofen and they're also taking warfarin, so that, of course, enhances their bleeding risk. DOACs also fall under this anticoagulant category. Our DOACs are our direct oral anticoagulation drugs such as apixaban or Eliquis, Xarelto, or rivaroxaban, Pradaxa, dabigatran, you name it. Anytime that these are used together, you do have a bit more of a risk of bleeding, so watch out for those. Next, we have our nitrates and our PDE5 inhibitors, and we worry about this interaction because both nitrates and PDE5 inhibitors can cause hypotension or severely low blood pressure when used together. Like I was saying, as with many of these drug interactions, the risk of hypotension increases when they're used together. And you might want to be looking out for several of the signs that appear on the left of your screen. So signs and symptoms of low blood pressure, besides actually having a recorded low blood pressure, it's something under maybe 100 and under for a systolic number and maybe under like 70 or something for a diastolic number. That's something that the person might feel faint, dizziness, or lightheaded, blurred vision. Paradoxically, you would think there wouldn't be a rapid heart rate with low blood pressure, but it is something that people might experience, a rapid heart rate or a racing, a tremor. Fatigue is also quite common. Cold hands, extremities, and a lack of concentration because they're probably dizzy and they're low blood pressure. You're not getting as much oxygen to the places that need it. So what do we look out for when these are co-administered? Well, it's mainly our nitrates. So our anti-anginal drugs, our anti-chest pain drugs, and those would include nitroglycerin or nitrostat and isosorbide mononitrate or ISMO and IMDUR. We also have, and then our PDE5 inhibitors, of course, they treat erectile dysfunction. So they are the classic little blue pill Viagra or sildenafil. We have tadalafil or Cialis and vardenafil or Levitra. So if you use those, you should absolutely avoid using those together to prevent what we would think of severe hypotension and potentially some very, very bad side effects. Likewise, we have our ACE inhibitors and potassium-elevating drugs. This is the big one that might often get overlooked because if ACE inhibitors, which are of course, our blood pressure lowering pril drugs, lisinopril, Zestril, enalapril, Vasotec, etc., if they're used along with other drugs which may increase potassium levels in the body, that's when we might have a risk of hyperkalemia. So hyperkalemia is high potassium levels in the blood, which can potentially have some very deleterious side effects. You have to, of course, watch out for duplicate therapy with ACE inhibitors. So you want to make sure that if someone is taking a ACE inhibitor and maybe they get switched because they're having side effects or problems with one of them, you want to make sure that they're not still taking that along with the newly prescribed ACE inhibitor. That's how we get duplication of therapy, and that's how hyperkalemia and problems with that may occur. And hyperkalemia, I should also mention, causes significant coronary problems, potentially a heart attack or irregular heartbeat, which can be very, very debilitating, devastating, and even deadly for certain patients who may experience that, especially if they're already have cardiac problems enough that they have to be on an ACE inhibitor, because that means their blood pressure is already elevated. We also have trimethoprim or Primsol. That's an antibiotic that's used to treat UTIs or skin infections that can also quite increase the potassium within the blood serum. So if trimethoprim is indicated to maybe treat a UTI, a urinary tract infection, or a skin infection in a patient who is currently taking an ACE inhibitor, we may want to make sure they can be treated with a different antibiotic that doesn't raise the potassium levels in that same way. Now, likewise, and you would think this is a no-brainer, but if a person is taking a multivitamin that has potassium in it, or even just potassium supplements, that's when we would also want to look out for if they're using it with ACE inhibitors and try to optimize our therapy to a drug that doesn't increase potassium levels too much to put them in danger. And likewise, not just with ACE inhibitors, but the same goes if trimethoprim is used along with the potassium supplements as well. Any drugs that may cause high potassium are fair game to cause hyperkalemia when used concomitantly, when used together. And if you have too many of them, if you're taking 4 potassium elevating drugs, that's when we want to be concerned, and we want to switch that therapy if we can. Next, we have an example of this is a rare example of a good drug-drug interaction, and that has to do with ritonavir and protease inhibitors. So if you remember, and you can look up our HIV and infectious disease antiviral lecture, protease inhibitors are antiretrovirals, which are used to stop the HIV virus, which can eventually lead to AIDS, of course. They're used to stop the HIV virus from replicating in HIV positive patients. So protease inhibitors work on the virus to stop them from being able to replicate. Ritonavir is also an antiviral, it's specifically an antiretroviral medication, as well as a CYP inhibitor. So it stops those CYP enzymes from metabolizing the PI, or the protease inhibitor, before it gets to work destroying the HIV. So the problem with protease inhibitors, you can imagine them as kind of fragile drugs that get cleared out of the body quite quickly. Well, that's an issue when HIV might take a while to destroy. It's a very difficult virus to treat. Luckily, we have newer drugs today that work quite well to treat HIV, But the initial problem when they were trying to develop these are like, well, we figured out protease inhibitors, but they don't stay in the body long enough to produce any sort of therapeutic effect. So what ended up happening? Well, our protease inhibitors became combined with ritonavir. So you get these combination pills or combination solutions to decrease their therapeutic their therapeutic effect at lower doses. So protease inhibitors are combined with ritonavir because ritonavir is a CYP inhibitor that stops those CYP enzymes from breaking down the protease inhibitors before they get to work killing the HIV virus. So by doing that, it builds up the concentration of the protease inhibitors within the body, and that increases the effectiveness of the protease inhibitor in fighting HIV. So a nice side effect of this, or a nice result from this, is also that this decreases protease inhibitor side effects, which while still effectively lowering HIV levels. So instead of doing what they did before ritonavir, which is just loading the person up with lots of doses of protease inhibitors, and these are kind of difficult drugs. They might cause nausea and vomiting, loss of appetite, some pretty nasty side effects when they're at certain doses. If you're able to decrease the dose and still get an effective therapeutic effect, that's excellent. That gives people with HIV a much better quality of life. It means their drug is working in their body as it's supposed to, sticking around long enough to fight the HIV virus, and ultimately keeping them at a level where their immune system is able to recover from the HIV infection and hopefully keeping them at an undetectable level. So our examples with this, ritonavir, otherwise known as Norvir as a brand name, often given with other HIV medications in order to produce this effect, this positive drug-drug interaction. And sometimes it's literally combined as is within a specific within a specific drug. So in this case, Kaletra is a combination drug, as you can see right over there. Comes as a liquid, but also comes as a tablet of lopinavir, the protease inhibitor, and ritonavir, which is our antiretroviral CYP inhibitor extraordinaire. Next, we have a very, very common, unfortunately too common, drug-drug interaction, which is beta blockers and calcium channel blockers. They cause an increased risk of heart failure when used concomitantly, when used together. So heart failure, of course, as you can see right there, is when the heart muscle becomes weak and it can't pump enough blood. You can get enlargement as well of the heart and cause fluid accumulation. It's a very, very nasty disease or disorder rather. And beta blockers and calcium channel blockers put these people who already have cardiac conditions at greater risk for heart failure when used together. So we try and avoid them as best as possible. They also slow the heart rate or cause bradycardia. That's a slow heart rate. You might recall tachycardia as a fast heart rate. Bradycardia is a slow heart rate. So we want to avoid, if we can at all costs, the combination of beta blockers and calcium channel blockers in therapy for patients with heart failure, high blood pressure, hypertension, or any other sort of cardiac disease which might warrant the use of one or both of these drugs. Beta blockers, of course, are your LOL drugs, our LOL drugs. They literally laugh at you. That's all for the people under 30 who are taking this course or watching online. Beta blockers, examples, of course, are atenolol or Tenormin, metoprolol or Toprol. You might see Toprol XL too. That's the extended release version, or Lopressor. It's another word for it. And Nebivolol or Bistolic. It's pretty common. Calcium channel blockers include our diltiazem or Cardizem, Cardia, and some others, as well as Verapamil or Calin. Next, we have our broad spectrum antibiotics and warfarin. Warfarin's going to come up a lot. If warfarin were trying to be approved today, it probably wouldn't have been approved because of how many drug interactions it has. However, it's a very, very old drug. It's a very effective drug. And for this reason, despite all the drug interactions, we still have it. But anyway, warfarin interacts with a lot of drugs. If there's an interaction problem on the PTCB and you're not sure what it is, but warfarin's an option, most likely it's warfarin. Anyway, antibiotics are considered broad spectrum if they kill or disable many different types of bacteria. And that often includes good bacteria that normally live in the gut. So what I should clarify with that is some antibiotics, what we like to see with antibiotics is having them very targeted. So if we know that, oh, this person has a staph infection, they have Staphylococcus aureus in some way, we're going to do an antibiotic that is specifically made, as specific as possible, to kill off the Staphylococcus, to kill off the staph infection, and pretty much as best we can, leave everything else in the body alone. Broad spectrum does not do that. Broad spectrum is often used if it's a very, very resistant infection, if it's very serious infection, or if there's multiple different types of bacteria which are causing this specific microbial infection. So you'll see broad spectrum a lot, especially in hospitals. But anyway, what broad spectrum basically does, instead of being very specific, it's like carpet bombing the whole thing. So the broad spectrum doesn't understand the difference between good bacteria and bad bacteria. It just sort of kills all of it, especially in the gut. So the problem is we have good bacteria in our guts, in our intestines, which help us break down and metabolize food and get nutrition from food, and as well as producing certain vitamins. So some gut flora or gut bacteria produce vitamin K, which normally helps blood to clot. Vitamin K is an important part of our blood, our circulatory system, which allows us the blood to coagulate and to have blood clots and to scab over and stop bleeding if there's any sort of injury. Well, warfarin is a vitamin K antagonist. It inhibits vitamin K, and that's how it thins the blood, right? So if you kill the bacteria, which otherwise help the blood to clot, and then give the patient warfarin, they're at very much an increased bleeding risk. Now, this can be resolved by simply adjusting the warfarin dosing, and that's done very, very often in an inpatient setting. But if you have a person who is put on a broad spectrum antibiotic, maybe at an urgent care clinic or something, and their doctor doesn't know about this, they would be at a significant bleeding risk if they're taking these. And these are quite common antibiotics. So for example, penicillins and cephalosporins, so like amoxicillin, ceftriaxone, cefdinir, many common medications which are used both inpatient and outpatient. There's lots of others. Check out the antibiotics lecture. I go into further detail about this, but warfarin and broad spectrum antibiotics are certainly something that cannot be ignored. Now, next we have digoxin and diuretics. So we have our loop and thiazide diuretics, and they increase the risk of digoxin toxicity by causing hypokalemia. So you remember hyperkalemia is that high potassium in the blood. Hypokalemia is low potassium in the blood. So low potassium levels that result from loop and thiazide diuretics increase the risk of digoxin toxicity. Digoxin, that of course is an antiarrhythmic medication. It's used to stop or regulate an irregular heartbeat, an arrhythmia. And digoxin is very easily influenced by this because it's what's called a narrow therapeutic index drug, an NTI. So it's very easily overdosed or underdosed. Digoxin has to be used very, very carefully and dosed specifically to the patient, or else, as you can imagine, it's a drug that regulates heart rhythm. So it's quite bad if you go over and create toxicity or go under and you're not adequately therapeutically regulating a potentially dangerous heart murmur or heart rhythm that the patient's experiencing. So diuretics to look out for with this are your loop diuretics, which is most commonly furosemide or Lasix, and torsemide or Demodex, and our thiazide diuretics, which you see all the time as hydrochlorothiazide or microzide, and chlorthalidone, which you see a bit less frequently. Now, the symptoms of digoxin toxicity are quite distinct. One of the most interesting ones, I think, is blurred or yellow halos or tint in vision. So people have what's called yellow vision. They'll see like yellow halos in their vision around objects, or everything will have a yellow tint. Their eyes don't turn yellow. It's nothing like that, but it's just the way that the vision and the light is perceived, it has a yellow tint. That's why I included Van Gogh here. This is a self-portrait that Van Gogh actually made of himself, but you'll notice the yellow tint to that portrait, and indeed to many of Van Gogh's paintings. So a fun fact, many scientists think that he actually probably had digoxin toxicity because Digoxin is, of course, it comes from a plant called foxglove, which can easily be mistaken if you're, say, foraging in a field or something, looking for lettuce or kale or something like that. You can make a mistake and make a salad with foxglove, and it could be potentially poisonous. So we think that perhaps Van Gogh was experiencing some digoxin toxicity because it might have been more of a stylistic choice or actually a medical condition that caused him to use those certain hues of yellow. So fun fact for the next time you're on Who Wants to Be a Millionaire or whatever, Jeopardy. And of course, as you would imagine, another sign or symptom of digoxin toxicity is an irregular heartbeat, because it is a cardiac glycoside. It regulates heart rhythm. So if you have a toxicity, that heart rhythm is going to get irregular again. Next, we have our aminoglycosides and our loop diuretics. So these are aminoglycosides, mainly antibiotics, which are gentamicin, tobramycin, amikacin, and others. Many times you'll see these in an inpatient setting as well. They're used to treat a very, very wide range of infectious diseases. But when taken together with loop diuretics, the combination increases a risk of ototoxicity, or hearing loss. That's toxicity of the ear, auto meaning ear in Latin, and toxicity, toxic. So hearing loss and also kidney damage. So they have to be monitored for that. And many times, especially when these medications are used to treat meningitis specifically, patients might be using aminoglycosides co-administered with the corticosteroid dexamethasone. And that decreases the chance of hearing loss by decreasing inflammation within the ears when these very heavy duty antibiotics are used, especially in pediatric patients. So likewise, remember aminoglycosides and our loop diuretics, they just cause an increased risk for ototoxicity. Treat with dexamethasone as a prophylactic or as a pre-treatment to prevent any sort of hearing loss, especially in those poor kids. Next, we have antihistamines and sedatives. This is an extremely common one that happens a lot, and many of these things are co-prescribed because if anyone has taken a Benadryl and you also happen to be on anxiety medication or even sleep medication, or it's just been a long day, Benadryl can really knock you out because drowsiness is a significant side effect of first-generation antihistamines. Second-generation antihistamines as well, to a lesser degree. But first-generation antihistamines are known to cause sedation. So, for example, as I said, diphenhydramine or Benadryl is super common, but we also have hydroxyzine or Vistaril, which is also used as an anti-anxiety or antidepressant, and chlorphenamine or Chlortabs. When used with other sedating drugs, patients should be careful driving or operating machinery, especially if they're just starting an antihistamine while taking these other medications for chronic diseases or disorders. This is one of those drug-drug interactions where we would like to say it's not like a total contraindication. That is, it's not like a big no that you can't take diphenhydramine along with, say, your Xanax or something for the day if you have a anxiety disorder and you're taking a benzodiazepine regularly. That being said, if you don't know how it will affect you, or if you're just initiating the therapy, we would want to avoid it, or we at least want to administer it before bedtime, because you're not going to have a problem with drowsiness if you simply take it before bed. So this drug-drug interaction really applies to first-generation antihistamines if you're taking antipsychotic drugs, benzodiazepines, especially muscle relaxants or anticonvulsants, opioids or SSRIs, those are your very typical antidepressant medications. Any other medication that might cause drowsiness can certainly have an additive effect and a sedating effect when used with antihistamines. And indeed, when antipsychotic drugs, benzodiazepines, muscle relaxants, opiates, or SSRIs are used in any combination together, they can also cause that same sort of sedation. So keep that in mind. Next, we have what's called our QT-prolonging drugs. Now, bear with me with this. This is a bit technical, but don't let it scare you. I'm sure if you've worked in a hospital setting, you've probably seen an ECG or an EKG, that little boop, bloop, bloop heart rhythm that is very, very typical. That part of what's measured on those specific EKGs or ECGs is what's called the QT interval. So each one of these little waves of a heart rhythm that you see here. This is just an individual heartbeat and heart rhythm. Every one of these waves has a peak and a trough, a high point and a low point, and they're each assigned a letter. Now, it turns out what cardiologists found out after examining this for quite some time was they found that the QT interval, the space between the Q wave and the T wave right here, is a very, very good measurement of if a person has an irregular heartbeat or an arrhythmia. And using differences in the QT interval and looking at it, they can diagnose what type of arrhythmia the person might have and the best way to treat it. So when this interval is increased in length, though, people would have an increased risk for arrhythmias and cardiac arrest. And there are certain drugs which can cause the QT interval, this little space right here, to grow in a way that causes the heart to beat irregularly and out of time. And that can cause an arrhythmia and a potential problem with an irregular heartbeat. And that, unfortunately, can even cause sudden cardiac arrest if it gets bad enough. If that QT is prolonged to such a degree, it can cause a cardiac arrest or a heart attack. Now, the use of multiple QT-prolonging drugs together should be monitored very, very closely. So all of these drugs, if you see them, especially multiple ones of these types of drugs on the same medication list, you may want to consider monitoring the heart rate and rhythm of these people to make sure that their QT interval is not prolonged. So this applies to certain antibiotics, specifically in the class of fluoroquinolones and macrolides. It applies to amiodarone, which is another antiarrhythmic, a heart rhythm regulating drug. It applies to some antipsychotic drugs to different degrees, but probably most notably haloperidol and quetiapine. That's Haldol and Seroquel. Those are the ones you probably see most regularly, but many other antipsychotic drugs do have QT prolonging effects. SSRIs are also very common culprits with QT prolongation. So that would be your citalopram, your sertraline, Zoloft, that sort of thing. And then quinine, which is a anesthetic, it stops people from moving during surgery. So you may see that drug as well. So always have to monitor for QT prolongation to prevent that risk for arrhythmia and sudden cardiac arrest. Next, we have another one which we were talking about earlier and alluding to is the increased risk of GI bleed or gastrointestinal bleed or ulceration when using together corticosteroids, or are colloquially known as steroid drugs, and non-steroidal anti-inflammatory drugs, or NSAIDs. So ideally, you wouldn't take them together anyway, right? Because you're either taking an NSAID to help with the inflammation, or you're taking a steroid to help with the inflammation. So you should avoid both together. With either one, you should take it with food to avoid stomach upset. I always especially recommend that to little kids if they get prescribed, say, an ibuprofen solution or something along those lines. But the food can moderate the ulcerative effect that you might see. Why did I put coffee grounds here? You may ask. If someone is having internal gastrointestinal bleeding, they might notice their stool is very, very dark, looking like coffee grounds. And that's a way to tell, because unless someone is literally like coughing up something or they feel a pain from an ulcer specifically, they might not know they're having this gastrointestinal bleeding until they check their stool in the toilet. So if they see this very, very dark, tarry stool, that could be a sign of internal gastrointestinal bleeding. Now, so we want to avoid corticosteroids and NSAIDs. We want to pick either one or the other in these cases. Examples of corticosteroids would be prednisone, otherwise known as deltasone. You get methylprednisolone as well, or Medrol. Those come in those little nice packs, as well as the prednisone, and dexamethasone, which is especially common inpatient. And our NSAIDs, as I mentioned earlier, aspirin, ibuprofen or Advil, naproxen, Aleve or naproxen, and celecoxib. And as I said before, there's generally a lower breathing, I can't even talk today. With celecoxib or Celebrex, there is a lower bleeding risk than other NSAIDs. So you can keep that in mind. Next, we have omeprazole and clopidogrel. So omeprazole is otherwise known as Prilosec, and that's a proton pump inhibitor, or PPI, which is used to treat gastroesophageal reflux disease, otherwise known as GERD or heartburn, more normally, or more informally, as a patient would tell you, I'm having heartburn. They're not going to say I have GERD. Clopidogrel, or Plavix, is an antiplatelet drug, and that's used to prevent stroke, heart attack, or other heart problems. Blood clotting as well. It stops those platelets from aggregating within the body, and that prevents plaque and things from building up, and it prevents stroke, heart attack, and other heart problems, especially after someone has already had it. It's that secondary prevention. It's prevention from having a heart attack happen again. However, when used together, omeprazole can reduce the antiplatelet effect of clopidogrel or Plavix. So as I mentioned before in the PK video, clopidogrel is a prodrug, so it needs to be metabolized in a very specific way within the body. Omeprazole throws a wrench in that process. So it decreases the absorption, and it messes it all up, and it decreases the absorption of the clopidogrel. It stops it from being converted into its active form, and then the Plavix doesn't work, and it increases the risk for blood clots, because even though you're taking the dose you're supposed to of that 75 milligrams of Plavix, it's not getting to where it needs to be in the bloodstream and in the body to do its job. And normally, if you're taking prescription medication, if you're on prescription omeprazole and clopidogrel, this is avoided. The doctor knows that you're taking Plavix, so he's not going to put you on omeprazole. However, Prilosec does come over the counter. So that's why it's very, very important to realize if you see this in a medication profile, a red flag should go up if you see both omeprazole and Plavix or clopidogrel on the same profile. I should also point out that not all of those drugs, not all of the PPIs mess up clopidogrel and its action in the same way. So there all are alternatives or other alternatives to treating GERD as well. Next, we have our macrolide antibiotics and statins. Macrolides inhibit the CYP enzymes that metabolize statins. So this is a classic CYP inhibitor issue. Macrolides increase the risk of adverse reactions associated with statins, mainly muscle pain or what's called rhabdomyolysis or rhabdomyolysis. And this is the breakdown, and very, very painful breakdown of muscles that has to do with statin toxicity, because the statin is not being cleared as well as it should be out of the body. It's building up to toxic levels, and it's having that bad effect on muscle pain and very, very uncomfortable and bad side effects for the patient. So examples of macrolides are azithromycin, Zithromax or Z-Pak, as it's most commonly known, chlorothromycin or Biaxin, erythromycin or Ariped, and tobramycin or Tobrex. And examples of statins, of course, they all end in statin, that's why we call them that, those cholesterol drugs, atorvastatin or Lipitor, lovastatin, Mevacor, simvastatin or Zocor, and rosuvastatin or Crestor. Next, we have hypoglycemic drugs when they are used together. Now, hypoglycemia is low blood sugar, which can be dangerous, especially if diabetic drugs are taken in combination. So we want to avoid taking these these drugs that are liable to cause hypoglycemia at the same time as best we can. So symptoms of hypoglycemia, as you can see over there, include sleepiness, sweating, pallor or pale skin, the lack of coordination, irritability, as well as hunger. So if a person with diabetes has these symptoms, they usually, if they've had diabetes for a few years, they would know, but maybe if they're recently diagnosed, they might not know exactly why they're feeling so bad and why they're going, or they keep going into these hypoglycemic episodes. So if multiple drugs which may cause hypoglycemia are co-administered, used concomitantly, there's a significantly greater chance for developing hypoglycemia. And this could be potentially life-threatening as well. If the hypoglycemia is bad enough, if it is low enough, it could potentially put people into diabetic coma even. Very, very nasty stuff. So drugs which lower blood sugar that should not be co-administered. So this following list, none of them should ever be given together, are our sulfonylureas, glipizide, glimepiride, others, metformin, which is the most common diabetes drug. It's the first line drug for treating type 2 diabetes, and our TZDs or glitazone. So pioglitazone, rosiglitazone. You never want to use those together. So if you ever saw a patient who was prescribed at some point both glipizide and pioglitazone, you would want to put a red flag and inform the pharmacist that, hey, something's not right here. They shouldn't have those together. Next, we have phenytoin as a CYP inducer. So you might recall our protease inhibitors were also, or ritonavir was also a CYP inducer, but this is a bad one. So Phenytoin or Dilantin is an anticonvulsant or anti-seizure drug, and that's used for epilepsy and similar conditions. It induces CYP enzymes and reduces plasma concentrations of drugs, which can lead to a decrease in efficacy of several different medications. Most notably, as your book will have you know, estrogens and progesterone. So that includes birth control. And birth control is one of the last drugs that you would ever want to decrease the efficacy of for obvious reasons. It can also decrease the efficacy of methadone, which is quite problematic for patients who might be going to a methadone clinic for treatment of substance use disorder with opioid medications. It's also very bad, especially if it's being used for pain management, maybe in an inpatient setting as well. You don't want to decrease the efficacy of a drug for severe pain. It might also decrease the efficacy of warfarin, which puts people at much higher risk for clotting. And again, why is it decreasing the efficacy? Because it's inducing those enzymes. It's increasing the rate at which drugs are filtered out of the blood plasma. If the drug doesn't stay in the body for long enough, it simply won't have time to work. That drain is suddenly becoming unclogged, and that drug is flowing out of the body before it gets a chance to clean it. So lowering the dose of phenytoin or increasing the dosage of the interacting drug can or might be necessary, but you have to look out for those side effects, of course, with both phenytoin and the other drug. Next, we have our beta-2 agonists and our corticosteroids. And when used together, corticosteroids increase the risk of hypokalemia or low potassium when used with beta-2 agonists. Now, it's quite easy to remember what beta-2 agonists are for. We have our beta-1 and our beta-2 agonists. The beta-2 are for the lungs, so they act on the respiratory system. Beta-2 agonists are easy to remember because we have two lungs, 1, 2, and it's beta-2. So beta-2 agonists work on the lungs. Now, however, when they're used in combination with corticosteroids, it might increase the risk of that low potassium. So we have to look out for symptoms of hypokalemia, which might include muscle cramps, weakness, fatigue, irregular heartbeat, and potentially respiratory failure. So this is serious stuff. Examples of corticosteroids, otherwise known as simply steroids, as we've said before, are prednisone and deltasone, methylprednisolone and medrol, and dexamethasone. And our beta-2 agonists or bronchodilators that work within those two lungs because they are beta-2 are albuterol or ProAir and Concomitant, and terbutaline, which is Bricanyl, Marex, and some others. Albuterol, of course, is the one that you see the most often. And it's important to realize that beta-2 agonists, like they exist outside of just singular medications. Concomitant is combined with ipratropium and albuterol. So you have to be aware of those brand names too, to be able to recognize that, oh, there is a beta-2 agonist in here. We should look out for hypokalemia just in case. Next, we have our alpha blockers and our antihypertensive drugs. So alpha blockers might be used to treat benign prostatic hyperplasia or BPH or an enlarged prostate. This, of course, is a non-cancerous enlargement of the prostate that is a pretty normal symptom of aging. But alpha blockers, when used with antihypertensives, which are also quite commonly prescribed to men of a certain age who might have an enlarged prostate, they might cause lower blood pressure and potentially severe hypotension, as bad as low blood pressure resulting in dizziness or fainting in men who are taking both alpha blockers and antihypertensive drugs concomitantly or together. So that does increase the risk. And why do we worry about this? Because it's quite a common drug interaction that occurs. A lot of men who are, say, 70 years and older are probably on some sort of cardiac medication. Well, hypotension, especially in older patients, especially when it's upon standing or from a seated or lying down position, they become a fall risk. So if you're working in a hospital, I'm sure you're used to seeing fall risk maybe written on a door or something. That might be because these patients, when they stand up too quickly, the blood goes straight from their head to their lower extremities, and they're not able to stay upright because they get a very, very severe feeling of vertigo, and that results in what's called orthostatic hypotension. That's going from your feet from a static position, a static or sitting position, a lying down position. And if you get up too quickly, It can cause dizziness and fainting. Now, antihypertensive drugs, of course, include our beta blockers, our ACEs, ACE inhibitors, our ARBs, our CCBs, calcium channel blockers, and our diuretics. So we should mention this dizziness, this risk of orthostatic hypotension with drug-drug interactions. It also applies if the patient is taking 2 or more concomitant antihypertensives. So they might be taking an ACE along with a calcium channel blocker, or an ACE along with a diuretic or something. And then if they're also taking an alpha blocker on top of that, that risk for dizziness, they're taking 3 antihypertensive drugs, that risk for dizziness upon standing and potentially fainting or dangerously low blood pressure gets increased substantially. Now, examples of alpha blockers are zosins or sulosins and stuff. So it's prazosin or Minipress, tamsulosin or Flomax, and terazosin, otherwise known as Hytrin. And lastly, for our drug-drug interactions, we have what's called the Holy Trinity. This is a benzodiazepine, an opioid, and a muscle relaxant when taken at the same time, concomitantly. So this is what's known as a high-risk drug combination. Now, thankfully, it's rarely prescribed for treating moderate to severe pain. It's really generally not prescribed outside of hospitals or closely monitored patient care settings like an assisted living, palliative care, hospice type deal, because these are very, very powerful anxiety, C2 pain medication, as well as muscle relaxants, which are also scheduled. Now, all of these 3 drugs enhance each other's side effects. So they have this synergistic effect where all of their side effects pretty much overlap, and you get a significant risk for respiratory depression and a breathing emergency. These all lower the respiratory rate of the patient to a point where they might just stop breathing entirely, because it works in the brain in a way that inhibits that cortex, which is allowing for breathing. It also puts patients at significant risk for abuse and misuse, because unfortunately, many patients with substance use disorder or a proclivity for substance use disorder, they're going to experience similar side effects when taking a benzodiazepine, opioid, and muscle relaxant as to when they get high. So it can cause a euphoric feeling, can cause pain relief. It's a narcotic, so it can be an intoxicating effect, and unfortunately has a significant propensity for potential abuse. And because it's so rarely prescribed nowadays, I would say that the Holy Trinity itself is a suspicious combination when prescribed outpatient. As I said, these really require pretty extensive and careful monitoring by healthcare professionals before they're prescribed. So if a patient comes with you, comes to your pharmacy, and they have 3 written prescriptions in hand, one for a benzo, one for an opioid, and one for a muscle relaxant, all written on the same day, and maybe they're looking a little bit suspicious, that's definitely a red flag. So this is an example, just another visualization of that trinity, and why we call it a trinity. You can see it's making a triangle right there. Carisoprodol is the muscle relaxant, the hydrocodone is an opiate, and the alprazolam as the benzodiazepine. They all sort of link together to create that propensity for a breathing emergency. So that would be reversed with Narcan, but even then, the combination of that muscle relaxant and benzodiazepine might make the patient harder to revive in that case. So things to be aware of, look out for the Holy Trinity. We'll talk about drug-food interactions in the next lecture. If you have any questions, feel free to contact me. Thank you.